Well, hello, everyone. Welcome to Medscape's education program today entitled Heart Failure Today, Where We Stand and What is Next. My name is Dr. Martha Gulati. I'm the Director of Preventive Cardiology at Cedars Sinai in Los Angeles, California, and I am honored today to be with Dr. Javed Butler, who really needs no introduction, but he comes to us from Baylor Scott White Research Institute, where he serves as the president. He's also the Distinguished Professor of Medicine at the University of Mississippi. Welcome, Javed.
Great to be here, Martha.
Well, I'm excited anytime I get to talk with my heart failure friends because I think it's become a really changing landscape about what we can do in heart failure in terms of prevention. So I think we've really come a long way. And I think I wanted to really get what your feeling is, but we know that heart failure is highly prevalent. 1 in 5 lifetime risk of developing heart failure, high morbidity and mortality, and one of the leading causes, in fact, the number one cause in the United States for hospitalization is heart failure. So Javed, what are the treatments out there that we are using that are actually changing or have the ability to change all of this?
Yeah, so I mean, the good news is that heart failure is not what it used to be even in the 1990s, early 2000s. There's a lot of therapies that have evolved. The bad news is that because of the risk factors that we have in the society, adiposity, weight, blood pressure, diabetes, all those things, that the incidence prevalence of heart failure is actually getting a little bit worse. So both prevention of heart failure and then aggressive treatment becomes even more important because this is, across the spectrum, it's a problem. It's more high risk of morbidity, high risk of mortality, quality of life issues, but also a societal issue in terms of the high rates of hospitalizations and costs. So, I mean, this is a real big problem in that sense. Now, in terms of the therapies, we had sort of the classic therapies and trials that were done in heart failure with reduced ejection fraction with ACE inhibitors and beta blockers earlier on in the 1990s. Then there were some studies done with MRAs, and let's sort of go a little bit more into the detail of MRA because there were some differences in different classes of MRA. But then we kind of progressed with ARNI therapy in heart failure with reduced ejection fraction. And then we kind of just broke that barrier of ejection fraction with SGLT2 inhibitors, which were shown to be equally effective in heart failure with reduced and preserved ejection fraction. And then we had some sort of niche therapies that have come for a specific population, like vericiguat in patients with worsening heart failure, ivabradine in patients with low EF and persistent high heart rate and normal sinus rhythm, and then some other therapies, device-based therapy. So there's a lot of things that we have in our armamentarium to change the trajectory of the disease.
Yeah, it's definitely more than diuretics, isn't it? That's what I feel like when I was training, diuretics and ACE inhibitors were kind of what we had. But now, just as a reminder for our audience, SGLT2 inhibitors, they work by reducing the glucose and sodium resorption, and that ultimately helps impact kidney and cardiovascular outcomes. And that's where we have some pretty strong data now that these therapies should be used in heart failure. So, but there's still some residual risk. So let's talk a little bit more about what have we put in the guidelines? Where do they fit in our practice is what I want to talk to you about the new therapies and the old therapies.
Yeah, so let me just quickly make a point about the diuretics that you mentioned. So look, I mean, the patients come to us because they're symptomatic and they want their symptoms to get better. But it is up to us to just make sure that we change the underlying biology or the pathophysiology of the disease, not only focus on symptoms, right? So when we give diuretics and people feel better, that's about it. They're feeling better, but you haven't changed the underlying biology till you give these foundational disease-modifying guideline-directed therapies. It will be akin to giving a patient with pneumonia, some medicines for cough and fever and say that the pneumonia is treated. Of course not. You've only treated the symptoms. So treating with these medications. So in heart failure with reduced ejection fraction, we have 4 classes of therapies: ARNI, beta blocker, MRA, and SGLT2 inhibitors that have class 1 recommendation. In heart failure with mildly reduced and preserved ejection fraction, now we have data with SGLT2 inhibitors in large randomized controlled trials as well. And now we have emerging data with MRA therapy in HFpEF as well.
Yeah. And I think that one of the therapies, that you've talked about just quickly was the MRAs. And I think that we have a lot of data showing that we really with all our heart failure foundational medications are not being used in the way that we had hoped. You see these great trials, we go to meetings, we get all excited. We think, oh my goodness, we can reverse heart failure. But the real life practicality is that I'm not seeing patients get on these medications. And MRAs is one of the medications that somehow, I don't know if it doesn't get started in the hospital or if it's just, people think it's a later therapy. I don't know what it is. But what do you think the story is about MRAs? And also, what can you tell us about things that are, the evidence that we have to date?
Yeah, I mean, this is a really important point. So, we all talk about these multiple registries and real world data showing that the medical therapy is not given to patients as they should be. But it's a trifecta, right? So there are three reasons why people don't get it. There's clearly inertia on part of the clinicians. So that's one problem that we need to overcome. But then there are a couple of other things. One is the perception of risk and the self-efficacy on part of the clinician. And then the third is real intolerance for the therapies, some of the therapies that we have. And intolerance could be subjective, like dizziness or whatnot, or could be more objective, like risk of hyperkalemia or those kind of things. So I think that developing newer therapies that are better tolerated, again, becomes pretty important in that sense.
Those are really great points. And I think, we've had the MRAs, and we have a lot of trials that, one of them dates back to my fellowship. So the RAILS trial, but we have these trials, the RAILS TopCat that studied spironolactone, then we had the eplerenone studies, and now we have these new non-steroidal mRNAs. And though these are more targeted and I believe reduce the side effects, as you said, how do you choose and how do you choose of these medications? What goes through your mind in the clinic?
Yeah, so if you sort of think about it, as clinicians, we would like to have all the drugs within a class be the same. So everything is a class effect. But we do know from a lot of previous experience that different drugs within a class may have different effects, right? So we know that, for instance, in beta blockers, some beta blockers improve heart failure outcomes, others don't. We know with DPP-4, some DPP-4 inhibitors worsen the risk of heart failure, some don't. So there is enough heterogeneity. So as clinicians, it becomes a little bit more difficult what to do when you don't have head-to-head studies. So then the only option you have left is to stick with where the evidence is and what the trials were done. Now, theoretically speaking, steroidal and non-steroidal MRAs, there are significant differences. And the differences are both in terms of their sort of the tolerability side effects as well as the potential for efficacy. So if you look at the classic MRAs, the steroidal MRA like spironolactone, there is more selectivity towards the kidney. It's not as balanced between the heart and the kidney. So that may have some implications in terms of the kidney-related side effects or hyperkalemia. But also, because they are steroidal, they have progestational side effects, right? So things like gynecomastia in men or menstrual abnormalities in women as well. So as you progress down and then you look at the non-steroidal MRAs like finerenone, there is more balanced distribution. So the effects are more balanced between the heart and the kidneys. So that partly may be the reason why hyperkalemia risks are low. But also, if you look at the basic science literature, the binding to MR receptor and the cofactors that are then recruited and further gene expression down the road is actually different for steroidal and non-steroidal MRA. So there's biological reasons to believe that these may be different as well.
Yeah, it's an evolving landscape. And I think we've had a lot of exciting trials recently that I know you've been part of that are actually really examining who's the right population that we can use MRAs in and what, especially the newer drug finerenone with less side effects, how to use it, who to use it in, and significant impact. So can you take us through a little bit about the fine arts study?
Yeah, so the importance of the fine art study is that the role of MRA in patients with heart failure and preserved ejection fraction was sort of up in the air, right? So we had data in heart failure with reduced ejection fraction with spironolactone and with eplerenone. But when the studies were done with heart failure with preserved ejection fraction, the TOPCAT study with spironolactone, the study did not reach its primary endpoint. But from there on, there has been this long controversy whether it was related to the drug or the trial. And there were some regions of the world where we suspect that the patients may not have gotten the therapy or did not take the therapy, or frankly did not even have heart failure. So that question was out. Now, in the meantime, we have these sort of newer generation non-steroidal MRAs. And as I said, there are theoretical reasons to believe that both the biology and both the side effect profile may be different for these. So they were tested in heart failure with preserved or mildly reduced ejection fraction, 40% or greater, and patients were randomized to finerenone versus placebo and were followed. And now we have definitive evidence that the trial was positive. There was a 16% reduction in the primary endpoint of cardiovascular death in total heart failure events, about an 18% reduction in total heart failure events and heart failure with preserved ejection fraction patient. And there was a 7% reduction in cardiovascular mortality and all-cause mortality. However, the mortality data itself was not statistically significant.
When you tell your patient about these medications and the new trials, particularly finerenone, do you describe the MRAs as MRAs or do you describe them as diuretics?
Well, so we do know that the diuretic potential for these drugs occur at a much higher level. So we know that data from the ascites and cirrhosis literature and whatnot, that you really need to give like 200 milligrams of, say, spironolactone to have the natriuretic properties. So the doses that we're using are largely non-diuretic neurohormonal modulating doses per se. So, when we give patients SGLT2 inhibitors, because they do have some potent diuretic effects, both osmotic diuresis and natriuresis, it's not uncommon to cut down the dose of loop diuretic. But I would not necessarily do that with MRA, at least not proactively.
Right. So it seems that we now have medications for the areas of heart failure that we really haven't had a lot of therapies for. I mean, now with the MRAs, we've got evidence in HFpEF and HFmEF. I'm not sure how we say it. And we didn't have that before. We didn't get enough time today to talk about even GLP-1 receptor agonists, but those potentially, at least in patients who have obesity, could be another thing. And that way we're addressing things about the cardiovascular system, but also the kidneys. And I think we're having a greater appreciation of how all of this is linked together.
Yeah, so that's a really important point that sometimes we miss, that the underlying biology for development of these common comorbidities and progression is actually overlapping. And therefore, we are seeing that the same therapy prevents the development of heart failure, prevents the development of kidney disease, and at the same time, if you have heart failure or CKD, prevents the progression of the disease. So, for instance, with finerenone in patients with chronic kidney disease related to diabetes, we know that these therapies prevent the development of heart failure. And now in HFpEF, we have data that it improves the outcome for these patients as well.
Yeah, such an exciting time in our heart failure and preventive cardiology world. Again, just to take us back, I mean, we know heart failure affects more than 60 million people, and it's the number one reason for hospitalization in people over the age of 65. But as Dr. Butler said, we have to do a better job in using our guideline-directed medical therapy. And, I always say that this needs to be done early, especially when we're making the diagnosis, not waiting, not thinking it's something that you're going to do as an outpatient. Maybe the device therapy will be later on once you decide what exactly is the right thing for this patient. But currently, we need people to remember that in the US guidelines, steroidal MRAs have a class 1 recommendation for HFrEF, but this recent evidence is really changing what we're thinking about specifically non-steroidal MRAs and their effect on heart failure with modified medium ejection fraction, and then heart failure with preserved ejection fraction. And this may really guide our future guidelines. There's so many emerging therapies that are being studied. So this is a really exciting time. Do you want to add anything, Dr. Butler, before we close out?
Yeah, I just want to take a second to talk about the issue of dyskilemia. So, potassium is a big problem in patients with heart failure, both high and low. Sometimes we are sort of much more drawn towards the dramatic effects of high potassium, but we forget that the risks are actually higher if you have hypokalemia as well. Now, we suspect, based on the biology, that the risk of hyperkalemia is less with non-steroidal MRAs than steroidal. We don't have head-to-head trials, so we just ought to be careful when we give finerenone to check patients' potassium and follow that. But the trade-off, the beneficial trade-off, is that the risk of hypokalemia is substantially reduced when we give these therapies.
That's excellent. All right. Well, thank you to our audience for being with us today for our quick educational session. Don't forget to go on the link to get your CME credits. You should be able to see that. And thanks for joining us today. And thank you, Dr. Butler, for all that wisdom.
Always great to talk to you, Martha.